Everything is going to be at that 40 inches. Easy to remember, the only number we're going to use. We're not using any 72 at all this chapter. And small focal spot, as Jalen had said the other day, because there are so many small bones in the face, that small focal spot is going to enhance that spatial resolution and really make those fine details pop a little bit better. And then of course, shielding, guys, don't forget the shielding until they decide that's obsolete, which they're still trying to do. Shielding of all the radius sensitive organs. And while you're at it, I mean, especially if you have a patient that's worried about, just put a whole lead jacket on them because you're only interested in the head area anyway. Extra protection is going to do them good as well. So y'all might hear some of that at TSRT where they're really going to start debating some of the shielding stuff. I'm sure it'll get brought up at some point. Keep in mind that has been a debate for the past 5 years. It looks like they're going to get their way and eliminate shielding, but if I was to wager a guess, here's what I think is going to happen in the next 10 years. They're going to take shielding away. You're going to have a lot of lawsuits of people developing cancers, and they're going to trace it back to that and reinstate shielding again. Mark my words. I guarantee that's what's going to happen. They're kind of playing with fire there, if you ask me. You'll learn more about that in Rad Bio, about the deterministic and stochastic effects of how they manifest in different forms, different levels of life. To me, I don't know, it's not worth the risk, if you ask me. Yes?
Is that you talking about them getting rid of shielding, is that just the state of Texas?
That would be like worldwide. They're trying to do that worldwide. They're saying with the advancements of digital technology, the dose is so much lower that it just doesn't, it's not worth it to shield anymore. But as you'll learn about radiation effects, even the tiniest dose of X-ray can have a chance of developing cancer later in life. So if you can even block that tiny dose from affecting a radiosensitive area, to me, the benefits outweigh the risks there in a lot of retrospects. Like why risk it? Because a high dose versus a low dose, they both have equal chance of developing something later in life, no matter what that dose is.
So what's the reasoning behind getting rid of it is my question. It
Technology.
doesn't hurt you.
Because they say that, well, two reasons. They say technology has evolved to the point where it's just pointless because the dose is so low. But they also say, they try to say, well, you know, if you put the shield on the patient wrong, you re-expose them anyway. But I'm like, how terrible a tech are you if you're always having to repeat for shielding? I mean,
Right.
that's just bad education, if you ask me. That's sloppy tech work. So I think it's silly, but they're really pushing it hard. But I don't agree with a lot of stuff these people
I have a
propose.
question.
I'll get you in a second, Shaheen.
Even though they say like they're getting rid of it, are we still allowed to do it? Or they're just
You
gonna
still
keep
do it
the
until
shield?
they officially say we don't do it
No,
anymore.
yeah, I know, but like after they
Oh
say
yeah, that's
like
your,
it's an option.
as a technologist, that is your choice.
Okay.
Absolutely.
Like I could be better.
I would still
I would
shield.
be better, like I would feel better if I was getting an X-ray if I was shielded.
I agree.
They
I
were
agree.
taking away.
So yeah, I get X-ray. I say you better put that shit on me. What do you think you're X-raying? Shaheen?
Mrs. Donahue, do you shield babies 1 kg and then incubate? Do you shield those babies?
Do I shield babies in the incubator? Yes, I do. Where I used to work, we had little shields about this big. They're like little ovals. They were not nano shields. Did you say nano shield?
Shadow.
Oh, shadow shield. Not a shadow shield, it was just a PD shield. It was like a little oval, and you would just slip it on the baby's genital
It
areas
was
before you took the
so
X-ray.
small, like never seen a big, and I think the 4-month-old baby, like a 4-month premature baby.
Mhm.
And,
And here's the thing, a pediatric, especially a preemie baby, is even more radiosensitive because their cells are still developing. So however you can shield, absolutely, yes. Even though you're probably not seeing that around here, they should have little shields about this big to put on the babies, yes, ideally. You have a question, Jay?
I forgot.
Okay, I'll come back to you.
Yeah, the coffee.
John's?
Whatever we're learning today, is that going to be the first test or the second?
This is all still first test.
Even though it's
So we're about to go over pathologies, yes.
Oh, okay.
All right, so the 5 most common positioning errors, guys, we went over these briefly. I put in red 1 and 2 because that is the most common case of mispositioning on x-rays of the head and face. That being your rotation and your tilt. Make sure you know the difference between the two. I'm sure some of us are still mixing that up in lab. I know I used to all the time, but remember, rotation is basically you're saying no, and tilt is you're curious about something. That's how I remember it. That's kind of silly, but rotation is when you're saying no to somebody. Tilt is when you're just really curious or you're just really tired and you're about to fall asleep in class. So you're tilting your head over like this. Yeah. Right, so you got it.
Tilt.
You got it. And of course, flexion and extension and the incorrect angles are going to be a big deal as well. Now, those angles are going to play a large part too, because if we do not utilize the right angles on the face and the head, that very small anatomy is going to get highly distorted and thrown all over the place. We got to be very, very mindful of the angles that we're using.
Mr.
And,
Donahue?
yeah,
I'm sorry, I remember my question from earlier.
Sure.
If we're not, if they want to do away with shielding, what does that mean for exams like the lower lumbar, or I'm sorry, lateral lumbar? Are we still gonna put the shield behind the patient?
so that would be a different case because that's not protecting the patient, it's just cleaning up scatter.
Right.
So in that case, yeah, you would still ideally
So
try
it
to
would
keep
still be a
using
part
that.
of the protocol?
Yeah,
Okay.
because the way I see it, even if they say, no, we're not shielding anymore, I mean, I'm sure the lazy techs are gonna just be jumping for joy, but they're not gonna get rid of all the shielding, they're still gonna be keeping that all in the rooms, I'm sure.
Okay.
So I don't care what they say, I'm still putting a shield on, especially if I'm sitting in there helping hold a patient, which, where I work, we did that all the time, so you better believe I'm still gonna use a shield. All right, so this is just showing you, once again, why it's so important. You guys all did this in lab. That's a PA mandible axial view. It's a combination of making sure that you have the correct part centered, you have the right rotation and tilt, patient is looking straight ahead, forehead's on the IR, and of course that caudad 15-degree angle to stretch out the rami of that mandible. All those factors combine to give us that optimal image. That's just a preview of what's to come when we get to the positioning, which you guys are already doing hands-on. And as you can see, some of these are rather complex. We're gonna go over all the little criteria, which is why I also split this into another test for you. But we'll go more in detail with that as we move on. The big ones where that error is gonna occur is gonna be on your laterals. How many of you are having trouble with those laterals in lab? You always, like, falling or burning is like, oh, it's tilted, oh, it's rotated, nope, IPLs aren't level. That's where people have the most trouble. One of the key factors is to make sure that you're obliquing the patient properly. So even though the head's lateral, the body's actually obliqued. We're not putting the body lateral. And a lot of people make the mistake of starting the patient lateral and trying to have them lean into the IR like this. That's gonna mess it all up. The only way you can get that head nice and firm against the IR is if we properly oblique the body, like you see this fellow right here. But look to the pupils. Those pupils are your best friend. Whenever you're doing your patient or your lab partner, just tell them, I want you to peer into my eyes, all romantically, peer into my eyes. Not like that, that'd be kind of creepy, but my point is, have them look you directly in your eyes because you need to follow their pupils. Stand directly in front of them and say, look directly into my eyes. Because if you're not, if you're like from the side over here and they're looking straight ahead, you're not gonna be able to follow those pupils properly. You get to be right in front of your patient, look straight into my eyes, then hold your pen up and make sure you've got that proper rotation versus tilt. You're gonna see it a lot better, but trust me, that is the key whenever you're trying to get this proper rotation versus tilt. Peer into your eyes, peer into your eyes, look to the pupils. Hold that pen up, make sure it's level. If you wanna go invest in a level, by the way, like a construction level, that might help you as well. Anyone ever use a level before?
Your phone has a level.
My phone.
Yeah.
All iPhone.
He doesn't have an iPhone.
Yeah, you wouldn't know.
I meant my phone has a level.
I can get a level on my phone too.
It probably won't be as accurate.
I guarantee it's even better than an Apple. But anyway,
Yeah.
a level will help you as well because it's the same concept. We want to make sure the pupils are leveled. It's like you're leveling a picture on the wall whenever you're trying to hang it up in your house. At least I hope you level your pictures in your house because let me tell you, one of my biggest pet peeves is I walk into somebody's house and I see a crooked picture frame because I can see it from a mile away. I'm kind of OCD like that. So
I've got some mirrors that are like slightly like
don't,
that.
Don't.
Oh yeah.
It gives me anxiety.
Oh, yeah.
Don't. Stuff that's uneven and off, it gives me anxiety. I can't stand it. But.
Oh yeah. That chaos.
Like y'all see how level this is now? Did y'all notice for the longest time that this thing was off level and part of the picture was up here?
Yeah.
Did anyone else notice that?
You can also
That's been driving me crazy for a year. They finally got that fixed, so much better, much better.
Oh, yeah, how long it is.
Look at this one.
Now make note, guys. Yeah, I got almost the same exact thing. When we say laying down, once again, I said the optimization is going to be when you're standing or erect, but recumbent is going to be reserved for our trauma positions. Obviously, a lot of patients coming with head injuries will be due to a car wreck or a fall. They're going to be on a backboard and a neck brace. And we just take that neck brace off, right? Why not? That's what all the other techs do.
That's above my payroll.
Correct. We never remove the neck brace ever unless they've been cleared by the doctor and they remove it themselves, by the way. They or the nurse. Don't ever remove that yourself. But we can still acquire the same views with them laying down. I will say it's a lot more challenging though versus standing. If at all that they can stand, not only is it optimal, it's going to be easier on you as a tech to do those more complex positioning. Also going to always show us air fluid levels. Like I said, you're killing 2 or 3 birds with one stone without having to repeat anything. It's going to be easier for what they call your hypertension patients.
How would you do an SME?
Unless you're singing.
Ms. Stein, how would you do an SME with a patient who has a C color?
How would you do an SMV in a patient with a C collar? You would not. So you would try to emulate it as well as possible. You would basically try to angle your tube into their neck and go like this direction, which would semi-simulate one, but it's going to be distorted. But you just try to get the best you can in that case. But likely they're not even going to order that. Usually when it comes to a trauma head view, all they're ever going to ask for is an AP and a lateral, cross-table lateral, typically. Then if they get cleared later, they'll come back for the remaining views.
But
At least in my
nowadays-
experience, that's how they've always done it.
Nowadays, they probably just go to CT.
What now?
They probably just go to CT.
Yeah, and that's the sad case. You know, when it comes to head work, as soon, oh, they got a paper cut on their temple. Oh, it's another CT. You gotta make sure the brain's not leaking. You know. Boy, they love to order those CTs on their head. That's a cash cow. Let me tell you, that is a cash cow. Oh, there's an eyelash missing. Send them to CT. Oh, there's a piece of earwax coming out of the ear. Send them to CT. Good Lord, it drives me.
Oh, they got a possible fracture? X-ray.
Huh?
Oh, they got a possible fracture? X-ray.
Pretty much. All right, pathology. This is the last part of the first section, so there is light at the end of this long tunnel. You can breathe now. Just a few pathologies we're going to go over, nothing too complex. We're going to go over the types of our typical skull fractures. We have 4 listed right there. This is not in your book if you want to take a picture of it. We have what's called a depression fracture. That's not when you're feeling depressed. It means that the skull has actually depressed inward. You have a compound fracture, which is a multifaceted break, just like a compound fracture in the arm, leg, ribs, whatever. You have a hairline fracture, which is often mistaken for sutures, because they look very similar to sutures. And a subdural hematoma. There's your big CT one right there. What is a subdural hematoma?
Clot of blood.
I say like blood on the brain. Blood on the
Under
brain.
I was gonna say love.
Big deal, big deal. Anytime there's a risk of a subdural hematoma, which is probably why they always panic send everyone to CT, they want to make sure there's no subdural hematoma, because that can obviously cause brain damage and unneeded pressure on the brain as that blood starts to pool inside the skull and the skin. It'll start pushing down on the brain and actually cause further injury, permanent injury.
How do they take a look at those hematomas with CT?
How? They do coronal and axial views, and you can see like it looks like a big, almost like a bubble. You can see it very clearly. I might have a picture of it, I
Is
think.
it pictured outward or inward?
Huh?
Does it picture?
Usually it's more internal. Yeah.
Would sagittal views give them like the width of it, or like how long
Possibly.
something is?
If they were interested in the width. All right, that's what a depressed skull fracture looks like, if you were curious. It's like a dent. It's literally a dent in the head. I used to see quite a few of these on pediatrics. Man, those toddlers, if you ever had a toddler, how do they run? They run with their head straight forward. It's like they lead with their head, and they, of course, collide
One
to
more
the
time, please,
wall,
for the camera,
they
please.
fall off something, or heaven forbid, they hit their head on the corner of the fireplace. Ooh. Man, let me tell you, when we were baby-proof in our house, that fireplace had a gigantic padding all the way around it. We were not going to risk that. If you have a fireplace in your house and you have a kid, whew, pad that thing up. Pad that thing up. We had so much.
Did y'all use
Our house looked like one of those padded rooms in a jail for the crazy people where they jump all around, don't hurt themselves. We had our whole house padded because, man, my 2 youngest, they were active toddlers. Yes, indeed.
How do they fix that? Or they just let it like go?
How do they fix that? Well,
They use a plunger.
as best they can. I think they can try to suction it up. Something like that. They might have to actually open it and like put the pieces back in place, or they might just leave it.
On
On a toddler as well?
So is that like a stellate fracture?
A what?
A stellate fracture?
Stellate
Where it's
fracture?
like a bunch of different originating from a middle point.
Is that the star-shaped one?
Yeah.
Stellate? This would be stellate. It's almost just like, it's more of just a dent. It's not really doing
So
like
it's,
the,
it's just actually.
yeah, it's not doing like the glass effect where
Yeah.
it goes all over the place. No.
I mean, I don't see how a bone can fold in like
Be
that.
surprised. You would be surprised.
Is that
Especially with young, yeah, that's what it looks like, by the way. There's another depressed skull fracture. This is on a baby.
Yeah.
So baby's obviously a lot more flexible. The bones are mostly cartilage. So, yeah, unless this one took a bite out of his head. I mean,
On the baby, do they also do like that, or they just kind of let them?
they try to pull it back out
Oh, okay.
as best they can and secure it, but I've seen some just grow with a dent in their head. Like, yeah, and it doesn't hurt anything, so they just leave it as is.
I'm gonna buy Andrew one of those, like those padded helmets. Have you seen them? They look like little mushroom.
Yeah, those peaches ridges though. You can already see the peaches ridges. All right, this is a compound skull fracture. That's whenever you've got multiple pieces coming apart. As you know, with upper and lower extremities, same concept. So obviously, very scary because what do you think's exposed here? Brain, yes, and that bone's coming out of the skin. It's an open wound. Open wound.
So with fractures like this, is it common to have brain matter coming out? Like,
Can do, yes.
I
It
came
very
in
well
on the
can
shock
be.
room that they were riding a motorcycle and they hit a SUV, were ejected into like the next intersection. They had it coming out of their nose and their ears.
Yeah, probably the worst. I mean, this probably wouldn't count as much as a compound fracture, it's just a complete disintegration. But the worst one I saw was out when I was in X-ray school at the trauma room at Memorial. There's a memorial in Lake Charles. The guy committed suicide with a shotgun to the head, and it was just a chunk of meat.
And you have to
It
X-ray
was just
that?
meat. Like, yeah, huh?
You have to
Yeah, we had
X-ray
to
that?
X-ray that.
Was he already?
I've heard that they have.
He was alive.
No, there was nothing left. It was ground up meat.
Then why should I do the X-ray?
You know,
It's forensics.
it's forensics, yeah.
Oh.
And probably beyond that, the worst one I saw there was a guy got hit by an 18-wheeler and it didn't even resemble a human being anymore. Like it was just, I remember it was a big black bag and basically his remains were in the bag. And there was like a leg coming out here, arm here, and the rest was just like looking ground up meat. That was pretty nasty.
And who
Did you
was supposed to
X-ray
wait?
like certain parts of the whole?
No, we just on that one, they would just called us and we just kind of stood there. I think, like what do I X-ray? There's nothing to X-ray.
What did you set the technique to?
We didn't take an X-ray on that one.
Yes.
We just stood there.
Oh my God, what's
But
that?
that's what I was talking about, compound skull fracture. This is with the skin peeled back, and of course you can see the separation of the bone, and there's the exposed brain in the middle right there. That's what it looked like on a CT. Of course, the axial views. But this is kind of similar. Remember I told you all that kid that had the pit bull scalpel? That's what that looked like. Like ripped the entire scalp off the kid. It was like an exposed skull like that. That's what it looked like. It was pretty gross. There's your hairline skull fractures, and this is why we learn our sutures, guys. Because I swear you don't want to embarrass yourself when you're in the hospital. You're there, you got some head work that comes in, and you know head work never comes in, so you're excited. Like Jay doing his head work the other day, and you take your X-ray, and you're like, man, look at all those fractures. There's just sutures, and everyone's just laughing at you
Yeah.
because you call it the sutures fractures. So we gotta know where the sutures are normally, so when we see something like this, obviously that's not normal, that is a hairline fracture. And that would be a
That
significant.
Tursica, boy.
Yeah, that's a pretty solitary right there. Yes, so you gotta be careful, make sure you know what you're talking about. You should never get excited in public anyway about a fracture, like I see some people go, oh wow, look at the fracture, like, yeah, take it down a notch, yeah, people can hear you. Yeah, watch what you're saying, the walls have ears.
And then one time I was like, I saw something and I was like, that, and my friend was like, shh. That was
Your
like
voice,
my first vacation.
your voice carries in a hospital. Hospitals are very echoey. You haven't figured it out. Like if you think you're whispering, it's almost like
You're
you're on an
so
intercom. People can hear everything you say in a hospital. Trust me. So if you're one of those people who likes to drop a lot of F-bombs, watch yourself. I had this guy I used to work with, this dude had such a potty mouth that every other word was the F word. I would be coming back from break around, like, way down by the EC. I'm like coming around the corner here like, F this, F that. I'm like, dude, seriously. Like, you could hear it in the whole hallway. I'm like, dude.
It's like
dude.
there's a receptionist in bone clinic, and she's always cursing nonstop. Like I come back and then
You talking about Chris?
She's talking about
yeah,
Crystal.
she's just like very playfully. She's just like, I mean, every sentence she just curses.
Yeah.
And watching World Star,
And I was over here trying to
fight videos, and patients are in that
I was over here looking at the
Well,
pocketbook. And I'm like, oh my God.
As I like to say, not to rain on anyone's parade, because you're free to say whatever words you wish. It takes a lot more intelligence to not use a curse word versus a curse word. The curse word's the easy way out. It takes a lot more power to keep it together and say something pleasant
But
versus.
she's not even mad. She's just saying
I'm
it.
just saying.
She's not even mad. Me either.
It's like
Anyway.
it's a part of her
It's a
vernacular.
part of her vocabulary.
Some people it is. Some people it is. I'm afraid my mom's gonna come around the corner and wash my mouth down with soap if I say something like that. Or my grandma's gonna come out of the grave and wash my mouth out. Goodness. Anyway, subdural hematoma, that's a big one, guys. Now, we are not gonna see this on x-ray, but this is why they always send head work to CT, because they want to make sure this is not going on. So subdural hematoma, it's in the word subdural, it's below the durum, and it's trapped between the skull and the brain, the blood. So the blood pulls up, and as you can see, it causes pressure on the brain, which can cause further injury, paralysis, or even death in some cases if it builds up too much. This is a progressive CT, by the way. This is how it started. This is how it already started to evolve within a few minutes when that bleed starts to spread. So they see this, they're gonna rush them to surgery really quick and relieve that pressure, because you can see, look what it's doing to the brain. It's compressing the brain. And obviously, if the brain's getting damaged, other parts of it are getting damaged as well. Yes.
So, which one did you say was first? The one on the left? Why does the contrast look like it's exiting the brain, or
This right here?
and on the right? Because it's already in the
Here?
no, on the image on the right, it's in the middle.
So this right here?
Yeah.
So that's what we call calcifications.
Oh, that's not.
So within the brain, there are certain areas that calcify. It's totally normal. As we age, you get calcifications in your brain. It'll look like little white areas like this. There's one there as well.
Mhm.
One of the most common is usually found right here. It's called the pineal gland. The pineal gland will calcify in almost every single person in the world.
Isn't that from
Naturally.
fluoride?
Hmm?
I thought that was from fluoride, like being in the water.
It just naturally happens as we age, and some people get more calcifications than others. And you'll notice when you go through CT, you start seeing those little dots pop up all over the brain.
Okay.
Totally normal though. Doesn't, as far as they know, does not cause any issues. It's just a normal part of aging.
I read somewhere that's where they think the third eye was, or when they.
The third eye.
Yeah, when like back in the day when people say like, oh yeah, my third eye is opened or whatever, it's just like their pineal gland is back there, and they say that it's the spiritual one or whatever.
Oh, okay then. Not sure what I think about that. Okay.
It's I don't buy into that stuff. I
It's
read
the
it.
third
Yeah.
eye because it tells you when it's like when it's dark, when it's morning, and when it's
Almost like
night.
an internal, like your internal instinct on things.
Your
like
clock.
sixth
Your clock.
sense.
Yeah, I'll look it up.
So as you can see, guys, this is two cases of a subdural hematoma on X-ray, and very difficult to see. In fact, if you're not really looking, you probably wouldn't even notice it. Where is it at on these X-rays? Can you see the subdural hematoma? Can anybody see it?
Pineal battery.
On the left one first. Right there, correct. So if you weren't really paying attention, you wouldn't really know. So this is a very severe subdural hematoma, by the way, because normally you're not even going to see that on an X-ray. But right there on the back of the head. How about on the right? Can you see it at all?
The lateral left side, or right side. Sorry. It's not. It's not above the zygoma over here.
Nope, it's right here. That's all normal. That's what that's supposed to
So
be.
why is that's supposed to look like that?
So very difficult to see on an X-ray, which is why, once again, if they fear there's a risk of subdural hematoma, they're not going to waste their time on this. They're just going to send the CT. Which in that case, that's wise, because as that blood pools on the brain, it's causing damage very quickly. We can't sit on that. We gotta move very fast. But at the same time, I still think they sometimes use it as an excuse just to run that insurance, you know, get that extra money. If you ever have CT exam, they are super expensive.
Yes, I've had.
Even with insurance, you got a big $10,000 bill coming in the mail.
Yes.
Yeah, you know what I'm talking
Yes.
about. Oh my God, a simple abdomen CT done, $10,000 bill with insurance.
So you had to pay
It's at least.
10,000?
Huh?
Did you have to pay the 10,000 or?
With the insurance, yes. Like even if you don't have insurance.
That's what I owe, after insurance paid for the rest.
So did you pay or was there another solution for it?
I mean, you get payment plans,
Oh.
of course. Yeah.
You think he's trapping jobs? What are you talking about?
Huh?
He's not trapping. What are you
No, I thought there was another like you can apply for like another.
He made a couple bops on SoundCloud.
Yes?
My bad. Like if I was disabled, I had a lot of carousel patients. They had good insurance, so they didn't pay that much for
Yeah.
CTs and
Certain people will get
Yeah,
a
you
lot
can,
better
you can go
with
to
insurance,
certain
yes.
spots and just pay $400 for a CT.
I don't qualify for the special insurance. I
But that's
got
what I'm saying,
no.
so it's cheaper.
What's the difference? Like,
I'll tell you the difference.
the
Normal,
doctor.
normal people insurance sucks. It doesn't pay for jack squat. But you know, if you're some of the less fortunate, you're using like Harris Health, things like that, usually will cover a lot more for you. It's the way that salaries and all that kind of stuff work. And checks and balances. But I'll tell you who has the best insurance. My youngest daughter.
Who?
Oh yeah, she's on Medicaid. Really? Because she was adopted, she receives Medicaid. Man, we don't pay anything. for that. I took her. She went to the dentist the other day, and she had 3 cavities. I was very disappointed because I'm all about dental hygiene. She had 3 cavities, so they ran out everything for us. She gave us the bill. It was just $0. I was like.
You was like, go ahead and fix it.
I was like, maybe I was disappointed initially, but I don't mind. It's all, you're good.
So did my mother get it too? Or like they only get it past
Only
2
she
months?
did. It's weird. Only she did. The first adoption, for some reason, the way the system works, it didn't qualify under him. But for her, because she was what we call kinship sibling placement, there's a lot of weird stuff with adoption. She was covered in Medicaid
So how
the
long
rest
did
of
she
her
get
life.
it? Oh,
The rest of her life.
the rest of her life?
And Benjamin and Lily both get to have college for free for the rest of their life, up to a doctoral degree in the state of Texas.
They better go to school. Yeah.
So I only have to pay for college for 1 kid. So.
Hey, and this is
Hey, but if she's
This
really
is
smart, she can
an
get
incentive
her
to adopt, or
Yeah, it's a perk for adopting. You get
so it's an incentive to adopt. Okay.
And it'll be like any college.
Any college in Texas. So they can go to Rice University.
Watch me snip, bro. Watch me snip, man.
So if you want to adopt anybody, I'm a sponsor through
If you-
Depelchin.
If you
Just let me know.
get an email from me in like 10 years, just
Yeah.
By the way, Depelchin, fantastic adoption agency. Like, if you ever are serious about that, come see me. I'll tell you all about it. Anyway, last one, guys. We're all over the place here this morning. Orbital blowout fracture. That's a big one, guys. It says it in the name. Is when the orbital gets literally blown out. It has what we call a teardrop sign. Basically, it's when the floor of the orbit gets fractured specifically. Now, why is that bad? Well, it can cause some major damage to not only the eye, but the nerves around the eye. And, you know, your eyeball just might fall on out of that socket, you know, if it's damaged enough. So, gotta be careful there. But that's a very common fracture with car wrecks, and actually, believe it or not, baseballs.
yeah.
A lot of baseball, people who are in baseball and softball, they get hit in the eye, typically they have that blowout fracture.
I'm sorry, that's when I'm gonna get ejected from the game. Cause I'm being so much pain, I'm gonna forget. I'm just be looking for the person through the ball.
So teardrop, it basically, so you see the orbital floor here, yes? You see the fracture? Usually as the pieces come apart, one piece will go down a little bit lower and it typically just kind of have like a teardrop look to it, almost like it looks like the patient's crying a little bit.
It just
That's-
kind of looks like a diamond.
Yeah, I mean, Obviously, it's gonna be a different shape depending on the fracture, but they typically just call it a teardrop sign. And then, of course, the fluid will accumulate in the maxillary sinus, as you see right there, because it's bleeding, of course. So that's your most typical type of orbital fracture that you'll see, blowout fractures.
So you can even see the inflammation like around their soft tissue, like near the zygomatic bone, the temple area.
You can. You certainly can.
Does it? Do the fractures only stay there and like connect to the supraorbital, infraorbital foramina, or does it look like it snapped right there? Like, is that?
I mean, it can be in multiple spots along the floor.
Okay.
Yeah, it doesn't have to
So
be just like the middle. It can be.
So it's not just the teardrop.
Right.
itself. Okay.
Right. All right, guys, that is the end of head work anatomy. Anatomy.
Part one.
Part one. So big deep breath. We're halfway through it. After this test, all we have left is positioning. We'll get through it. Yes.
You mean
So we
destroying
have
the ring?
this test,
Yes.
a positioning, and a diaphragm.
Correct. Correct.
We have 3 tests. We have this test, the positioning test, and the
All right, guys, go ahead and take a break. Take 15 minutes. Come back at 9:06, and we'll do our little test.
Oh,
you didn't pay your bill.
I didn't pay my bill. They're not paying my bill.
They're gonna shut it off, Mr. Donahue. Lights.
So if y'all want to pair up, 3, 2.
You said if I'm getting hip pay. You know, the internet and stuff is tricky.
Okay.
Yeah, I think it's gonna work.
Okay.
I'm gonna roll over there in a little bit.
Is it gonna get in, girl? You know, this internet be acting up.
Yeah, I'm so. We have to pay for student ones now too?
That's my favorite scene right
They
there.
pay for everything now.
This is why we like
Yeah, when she said, he said, no man can kill me. She ripped off that helmet.
I
and
am
said,
the
I'm
man.
not a man. Girl was going out there for a uncle.
Did Mary die because of this?
No, we just
No.
got injured really bad.
They stopped that fool like it was at a Travis Scott concert.
You able to get in? What you got? You're like, I'm just.
I'm not ready, but.
you wear my
Oh. Yeah, you
Monty.
I was.
You wanna see this one?
I don't know what's
That's Monty and Logan too.
Yeah.
Oh, there we go.
Yeah, we know that one. Mama.
Got a unicorn?
JC? Well, at least it's right. You got your earphones on.
Yeah.
You got your earphones on.
I left my home today.
Yeah, so good.
Oh, well, if anyone has it, might as well.
We got room for one more. So let's go.
I thought he changed your name to Des. I seen Des. I said, how you gonna change your name to Des?
From solo.
Des. I thought he changed his name to Des.
I mean, I am still. We should all be skeletons.
Always skeletons.
JC.
Where does C come from, June?
What?
Where does C come from?
Alright, let's use our critical thinking.
Oh, really?
They're a team.
Oh, you guys are playing. I didn't know you guys were playing together. What's that? I thought Cody had his own name.
No, you know what that was?
What's that soft tissue in the
I was like, come on, use your critical thinking, you can figure this out.
I thought I was
That is-
That's what that was.
Everybody on? Everybody on?
John, I still can't believe that. I'm not
Bro.
gonna let you live that down. You're gonna be a tech, and some students
that
are
was
gonna
in the
come your way. I'm gonna
beginning.
send them to you.
Hey, Mr.
What's Saji?
Nah.
Mr. Saji, what's that soft tissue in the middle?
Some,
Oh, you see how it points to the fracture.
He's gonna be like, oh no. Go ask Jay. He likes to roll over his own feet.
That's true.
No, they're good.
And patience followed.
Oh,
That's cheap.
I did do that. I'm sorry.
no cookie for you. That's
What else has happened to you?
what hasn't?
What hasn't? Yeah.
Threats at the red light.
Yeah. Don't tell them to plug anything in.
Yeah, please. Oh, here, tell the power just went down.
Just went straight into J.
E is pointing to what anatomical landmark?
Oh, come on.
Casey, where's E? Where's E?
Up there.
That's the foramen ovale. Ovale? It's the foramen magnum.
Don't start, Jay.
It's not. I'm acting like an auntie.
Rally.
You better stop.
That's right.
You better stop.
Yes.
Oh, like
Oh, you don't even have a little hole. That's tiny.
That was a hard one. That was a hard one.
Can we turn out the
For us to
lights?
see on the arm.
Turn the lights out.
Is there any way you could pop?
Thank you.
Who's LSU?
No idea.
Look on the screen. C is referring to what landmark?
Oh no.
Oh.
That's really what I guess they heard.
Yeah. What?
Supraorbital groove. That's where the eyebrows are.
I thought the
that was
superciliary.
arch.
The superciliary was the eyebrow.
I didn't know there was a groove.
Oh, I apologize. That's from Bob Trigger.
Come on, man.
So, all right, so let me do a little mini lecture here, guys.
Let's
So,
start the game over.
superciliary arch. Yeah.
Is where the eyebrow is.
Yeah, that's what you had said. Come on,
Supraorbital
Donahue.
groove
I didn't know we had
is
that.
a very obscure thing that's like almost in the same spot that was in Bob Trigger. I'm sorry. No one got that right though, so
One
well,
person.
one person got it right.
You by default.
Who
But
is
yeah,
it?
don't take a picture of that one.
Start the
Omit that.
game over.
Omit that.
Pick that person out.
Dang! Bunch of sharks up in here.
was that
Landmark
LSU?
is C pointing to.
Alright.
Or C.
Maybe right.
You said what?
That's what we did. Camp.
Are you guys LSU?
Camp,
Oh,
right?
sorry.
Lazy on his feet, guys. Right here.
Look at me.
Dang. Oh, I'm so sorry.
I see you on the
I'm
board.
so sorry.
D is referring to what cranial bone?
Where's D? Can you point out?
Oh, yeah.
I'm sorry, I did not realize it was going to be so small up here.
Yeah.
Kind of blind up in here, you know.
The parietal bone, correct. The parietal bone. It's the green area right here. Parietal. S refers to what sinus?
Where's that at?
Right here.
Ooh boy. Yeah.
This is oil sinus. That's what that looks like.
Yeah.
Labeled.
It is labeled.
Oh my god.
There's two S's. So
Cody,
it's like,
why
well,
you keep
it's one of the S's.
I was like, M is.
This is practice for TSRT, guys. Come on. Practice for TSRT.
I swear to god, TSRT is labeled.
A is pointing to what landmark?
I know this one.
That was
Very
quick.
good. The glabella. Glabella. Area between your eyebrows.
This is not what we did.
Supraorbital margin.
You could put-
H is referring to what landmark?
Where's H?
H is right here.
Oh, that's just anterior.
That selling person.
Clavis.
Interior clinoid process. Here. Here's the cell turcica. There's the curve. There's the posterior. There's the anterior. Dorsum clivus. Right. I is referring to what landmark? Right here.
Oh, shit.
I think it's
The dorsum cell is correct.
so.
I thought that was the
From this
Turk.
view, this is gonna be the dorsum celli right here.
I thought it was
So
pointing on that
where's
line.
the clinoid process?
E is the clivus.
Is the clinoid process not marked?
They are not. So posterior clinoid process, so be careful on this. So when we see the posterior clinoid process, we're used to seeing it from that side view, yes, the lateral. When we look straight down into the skull, the posterior clinoid processes are on the sides right here, but the dorsum celli is in the middle right here. But only from this particular view. Clinoid processes are on the sides, dorsum celli in the middle. and
Was
right
that?
below is
But that
clivus.
was the posterior
No,
side,
right,
right?
he said right below.
But-
That is the posterior side,
Okay.
yes.
But in the book, when you're labeling, that line is called
What is
the, cause it looks like the eye is pointing to that line. In the book, it's called, it starts with the T, the T-U-B.
The tuberculum cell?
Yeah,
That's
so-
in the front. It's on the anterior aspect, up here.
Yeah,
They asked him.
Tuberculum celli is up here.
It's not the ridge
in
underneath
the
it,
book
right?
is
Is it right,
different.
it's the line?
You have to show it.
Yeah, I mean, it just looks good.
Oh.
Alright, A refers to what landmark?
Where's A?
The only thing that's colored.
Careful now.
That's gonna be that squamous portion, which is also the weakest part, remember that? And it's been on what cranial bone? Temporal. Squishy squamous.
But the whole purple portion was the temporal though?
Yes. L is pointing to what facial bone? L is right here.
Oh.
Clue is there's two lines. It's a pair. So here's the palatine, which is right behind the maxillary, which is right here. Maxillary on the roof of the mouth. Right behind is that palatine, right here. That was a hard one. That was that won't be on your test, by the way. I'm not gonna be that obscure.
Thank you.
What's the bonus question?
I'd be very generous, thank you.
H is referring to what junction?
Oh my god.
Oh, I already forgot
It's
what
directly from the picture you guys have. Asterion. Asterion. Make sure you know those junctions, guys. There's 4 junctions. Asterions over here. By the way, guys, if you look at the top picture, it gave you the answer.
Oh, now you tell us.
The C is so tiny we can't see it.
Just
Hey,
saying.
we don't side shame. Stop it.
LSU representing Louisiana peeps here, you know. Just saying.
I wonder who did it.
C is referring to what cranial bone? Right here. Purple. temporal bone. Temporal. Wrong answers coming up in the center. What is A referring to? Right here.
Is it pointing to the space in between or the bone?
No, it's the anterior clinoid process, dude.
Don't listen to me.
It's the anterior clinoid
It's
process.
the,
You know it's right because there's two
it's the
answers.
saddle.
You say it's too much.
Sella turcica. Sella turcica. Space right there. LS and RF. F is referring to what anatomy? This round part. Got that round part on the talon's view. Foramen magnum. In fact, that's the only foramen you're going to see in this view, by the way. That foramen magnum, which has what inside of it, by the way?
Spinal cord.
No, like on this, like in this view, what's inside the foramen magnum? What part of the sphenoid bone are we seeing through that foramen magnum?
The posterior clinoid process in the nerves. Say?
Correct. The posterior clinoid processes and the dorsum celli, which is what B and A are labeling, by the way. And so, I'm sorry, it's a hard to see picture that's showing you.
Test can use like.
The test, which I've already made, by the way, guys, the pictures are a lot better, trust me. Yeah.
Is this just like
No. I mean, there's questions like this on the test, yes. The test is very.
You can do it.
We'll talk about it in a second. I'll tell you all what to expect.
You can use my sinus image.
Oh,
Where's D?
what would have been a good one to use? Oh, D. D is referring to what suture. Where is D? Oh, right here. Sorry.
Where is D?
I couldn't see it either. I'm sorry.
I think so. Yeah, I couldn't see it at first, so we lost some points.
Lambdoidal.
Ooh,
Good. Everyone got that right. Lambdoidal. All right. D is referring to what facial bone? This one right here in the nose. That was a bigger picture. That's the inferior nasal concha. Inferior nasal concha, which is very low, closer to the maxillary border right here. Ethmoid's going to be up here behind the nasal bone. Alright. F refers to what suture? Right here, guys.
Been your friends.
As the lambdoidal suture. This is the back of the skull. Remember that coronal is going to be towards the front, guys. Coronal connects the frontal and parietal bones, which is labeled there, by the way. Coronal suture.
Who are you?
Wrong answers.
Wrong answers.
Surprising.
D is referring to what cranial bone? D is pointing to this blue right here. Blue. My cursor.
I was gonna that's not this one. I need to give her a heads up. I didn't want her to. Yeah. Okay, so I'm here.
That's going to be the ethmoid.
Oh,
Watch out for that ethmoid. For whatever reason, some of them ethmoids, whether it's an ethmoid sinus or cranial bone, people tend to miss that the
Oh,
most.
can't even see it, but it's in there. It's not in there.
Right. What is B referring to? Right here. And let me make sure I clarify this because more people make a lot of mistakes. I'll go through each of these letters. If I'm pointing up here, you'll see that's at the point of the cheekbone. That's your zygomatic bone, also called the zygoma, also called the malar.
So
Directly in the middle is the zygomatic arch. If the arrow's down here, it's just referring to the temporal bone. So zygomatic bone, arch, temporal bone.
Can you point them
But
up?
keep in mind, A and C come together to form an arch. Make sense?
what's wrong with their jaw?
Form together?
A and C, which would be the zygomatic bone and the temporal bone. They both connect to form that zygomatic arch, which you see right here.
Is their jaw broken?
Who cares?
Hey, so I asked the question like just for myself.
I don't think it's broken. I think it's actually, the head's not tilted all the way backwards. So it looks a little funky. Is someone's hand, was someone's hand up?
Somebody's hands up.
C is pointing to what landmark? Right here. That is the outer campus. Outer campus. Very good. E is referring to what cranial bone? E is the red area here, guys. The red area. Alright, that's the sphenoid. And be careful, guys. Make sure you know your order. This dark blue here where F is the ethmoid. Excuse me. Right behind that is sphenoid. Then right behind that is temporal. In that order, when we're looking at it from a lateral view like that. And what's this little green thing in front of the ethmoid here? That's that lacrimal. So make sure you know that order. So it tends to mess some people up. Alright. This diagram is labeling what cranial bone? What cranial bone is being labeled there? It's, it's colored by the way. That bat shape. That makes you think a little bit backwards there. Sphenoid. Sphenoid. It's that red bone that we're labeling here. It looks like a butterfly or a bat. Unique shape. M is referring to what sinus? Here. Kinda tells you. Kinda tells you what it is.
The answer's right there. It's either mandible.
As the maxillary sinus, correct. There is no such thing as a mandibular sinus. Keep that in mind. B is referring to what landmark? B is right here, guys. Protrusion coming up right here. And that is the Christa Galli. Now the question is, did Christa Galli get it right? I don't know. I can't see Christa Galli on here, so it remains a mystery. A is pointing to what landmark? A is right here, guys. This whole structure. Well, the upper structure, I'm sorry. This superior structure here. That's the perpendicular plate. Perpendicular plate's found on what cranial bone, by the way?
Yeah.
Ethmoid. What's the perpendicular plate connect to? To form the what?
The bony nasal septum.
Bony nasal septum. Good. pointing to what landmark? This
So you need
portion
the
right
mouse
here,
degree.
guys. This portion right here. It's referring to. Vertical portion of the ramus of the mandible. Mandibular
Oh, I didn't
condyle
see.
would be up here,
I
guys.
didn't read
Remember the
that. I said
mandibular
mandible and I
condyle.
clicked it.
Hey guys, one way to remember that, mandibular condyle fits into what cranial bone? Temporal, making the TMJ joint. And down here's that lower portion, that vertical portion of the mandible. Thus it has to be the ramus.
18 in a row. Golly.
All right, last question. C is referring to what landmark? C is right here, guys. All important thing I told you not to forget. These X-rays.
I feel good about that.
Petrus Ridge. Petrus Ridge.
Could you send us this Kahoot?
I sure can.
Thank you.
All right.
And yes, Chris Galley got it right.